like to start with? Pharmacology?
Yes.
Pharm. Okay. So is there something specific you want to focus on, or just kind of do like an overall review?
Probably just an overall review.
Overall. Okay.
When I go through the Andy RDH book, some of it is familiar, but it doesn't make a whole lot of sense.
Okay. Let's see. Okay, yeah, I'm going to use my DHS book here because they've got it really, really, I mean, it's 12 pages. That's it. So it's really
This one's
condensed.
like 40.
Yeah. Yeah, this is super condensed. So one thing that they definitely said to go over are the Controlled Substances Act, to know that Schedule 1 has the highest abuse potential.
Mhm.
And that Schedule 4 includes Valium, also known as diazepam. And sometimes that's prescribed in office for anxiety, for dental anxiety. So patients who have anxiety sometimes will have that, sorry. There we go. Okay. So some patients will have that prescribed, and your doctor will have to list that they prescribe that, and it'll go through the check system.
Diazepam, you said that was a Schedule 2?
Schedule 4.
4? What's the, is diazepam the commercial name for it or the generic?
Generic. Valium is the brand name.
Valium is what it is.
So as long as you can determine what's a Schedule 1, 2, 3, 4, or 5, you should be okay there.
Okay.
Did y'all go over the log dose effect curve?
That was, I'm sorry. Hey, I'm going to take that one. Yes, but it was kind of confusing. I know it was potency. It could be more potent.
Mm-hmm.
One of them could stay the same. I'm trying to think of it. There's a... What was it? The potency, it could be, it's the, how much of the drug you're getting.
Okay, so
Right.
basically, yeah, this is a relationship between dose and response. So, different drugs, depending on the dose, you'll have a quicker response or a delayed response. Think of it like ADHD. Some of those medications are time released and some of them are immediate effects. So when you look at do you have a picture of that curve at all? Do y'all have one available?
No, it's in the pharmacology book. I don't have that one out.
Okay, let me see if I can draw it.
Is there one in the Darby book?
I'm not sure. Honestly.
Looking. Mom, I want to be playing Fortnite. Okay. Get some rose. Okay. There's one in the book on 327.
Okay, 327. Okay, so right here, we're going to talk about maximum response on this side, and then effective dose, percent of effective dose on this side. So what we want is a therapeutic range. So that's where the dose might increase, but that's where it's working. And then the maximum response is where the curve plateaus or flattens out. So right here is our maximum response. So when we discuss potency, the activity of a drug related to dose, that's what we're talking about. How strong is it? Potent. This is also described as the amount of the drug necessary to produce the effect that we're looking for.
Okay.
And potency is greater when the dose is smaller. So I'm going to erase this little chart and then type some keywords here. Yes, I'm recording.
You said potency is greater when the dose is lower?
Yeah, so when the dose is smaller, the potency is greater.
Mommy.
Okay, so then we move on to efficacy. This is the maximum response of a drug, regardless of the dose.
So this one, it can be whatever you give a patient, it's the dosage, you can give them 3 and it's the same as giving them 6.
Right. There's a maximum response and then it stops. Oh, thank goodness. Yeah, exactly. Efficacy. That's good. Okay. Onset. What does onset mean?
How long it takes for
Yep.
it to
So
work.
how long before there's an effect? Duration is the length of time that it has an effect. And then half-life. So did y'all go over half-life quite a bit?
Just a little bit. We explain how it all works.
Yes.
I know it's when it stops working, right? When
Well,
you can't detect it in the blood.
it doesn't necessarily mean that it has stopped working. It just means that it's the half-life is the amount of time that it takes for the drug to fall to half of the original blood level. So it's still there circulating in the blood, but only at half of what it was at the beginning.
Okay, and that depends on how fast or slow your body metabolizes it.
Yes, and it's dependent on the kind of drug. That's all you need to know. You don't need to know any math. You just need to know it's the time that it takes for that drug to be half in the bloodstream.
Okay.
I don't do math. My best friend just started her prerequisites for nursing school, and she's like, "Can you help me with the algebra?" I was like, "Probably not." That's not something that I can do. I was like, "I can help you with anatomy, physiology, chemistry, biology, but I draw the line at math."
Right.
Not
Numbers
happening.
are hard.
Yeah.
We were trying to figure out rad this morning with Miss Lewis, and we finally got it. But I was like, I don't know the math to it.
Rad, the absorbed dose?
Uh-huh.
I just look it up.
Well, it was on one of the questions yesterday. It said, if you were 2 feet away and got 2 rads, how much is it? 4 feet or something.
Yeah, I get you. That's not
yeah
fun.
the
Hi,
inverse.
Kathy.
Yeah, the inverse square law, Nicole. Laura.
Yeah. Ugh. Okay. So now let's start talking about routes of drug administration. So there's 2 major groups, enteral and parenteral, or however you say it. I probably say half of this stuff wrong, but Maybe that helps you remember it, you know, if I say it funny.
Exactly.
All right, so enteral. What do you think of when I say that word, or enteral, enteral?
Like entering the body.
Okay, yeah, entering the body, the liver. Okay. So basically, this is placed directly into the GI tract, and there are only two ways to get in.
Yes, upper and lower.
Yep, the front or the back. That's
Yep.
it. So when you think enteral, think GI tract. There's only two ways. So when you think parenteral or parenteral, it bypasses the GI tract. So it either goes through the GI tract or it bypasses it. How do we bypass the GI tract?
Injections.
Yes, with a needle.
Would topicals be
Parenteral.
parental? Okay.
So yeah, it includes needles, inhalation, topical, and sublingual. Because when you think about topicals and sublinguals, especially inside the mouth, it's being absorbed into the bloodstream directly from those mucosal tissues rather than being swallowed and then distributed.
Okay. He did tell us we need to know that intravenous is the most rapid one.
Yes, because you can't take it back. Once you push something in an IV, you can't get it back. So that's the danger of intravenous. So let's break these down a little bit. When we talk about the oral route, what are some disadvantages to the oral route?
It can be hard on your liver.
Okay, it can definitely be hard on the liver or the kidneys.
It can cause stomach upset.
Yep, GI upset, good. Yeah, slower onset for sure. Why is it a slower onset? What's our area for absorption of these drugs?
The intestines.
Yeah, the small intestine specifically. So think of how long the small intestines are, and to be absorbed, it's got to get all the way through there. So it takes longer for the onset of these drugs. However, it's the safest because we have, you know, ways to counteract things that were swallowed. Okay.
What are P450 enzymes?
What? I don't know. P450? What is that in relation to, Amanda?
It's on the internal route. It says orally delivered drugs must pass through the hepatic portal circulation, which can inactivate some drugs, called the first pass effect, and then a
Okay.
bullet point P4050 enzymes.
So let's simplify it a little bit. The first pass effect that you're talking about, that's only with the oral or the oral administration. So what happens is that a drug can be inactivated by acid. Where are we encountering acid when we swallow a drug?
The stomach.
Okay. And then enzymes. So your body produces enzymes to counteract whatever we put into it. This is how we digest things, right? We break it down. So the first pass effect occurs when these drugs pass through the liver or that hepatic portal circulation. And that's going to reduce the amount of the effective drug.
And they're called the P450 enzymes.
According to this, you don't even need to know that. Just know that the first pass effect goes through the liver, basically.
Okay.
And that it reduces the amount of an effective drug. So what do you think that means for drugs that have a high first pass effect? What do we need for those drugs?
Has a high first pass.
For them
Would
to
you
be
need them to be
effective, what do we need? So first pass means that basically the liver has made it less effective. Yes, okay. So you have to take more. You would need a larger dose of that drug to get the same effect because the liver is making it less effective. Okay, ready to move on?
yes.
Okay, so we talked about the oral administration. What's next?
The pateral.
Nope, we still have one more for enteral. We covered the front, now we've got to cover the back. So,
The suppositories.
yes, rectal. Rectal route of administration. Of course, this has poor patient acceptance. People don't want to do this.
Yeah.
And this can be used if a patient is vomiting or unconscious. So if they're vomiting, you can't establish an IV, then you might have to go to the rectal route. However, this has poor and irregular absorption. So when something goes from the mouth through the GI tract, think of how many things it's encountered, acids, enzymes, the stomach, it's gone down the esophagus into the intestines. So before it even gets to where we need it to be and to start working, it's already been diluted by each step. When you go the opposite way, it hasn't been diluted at all. And we don't know how that small intestine is going to, process it. So it's a very irregular absorption going from the rectal route.
When you do that, can it, with all the bacteria there, will it mess with it at all, the drug?
It depends. If it's like if it's an antibiotic cream that you've put in that area, then it would mess with the good bacteria and you might end up with a fungal infection there. So I think what they're talking about is more like emergency drugs, and I doubt that bacteria would have a large effect on it. That's a great question. I never thought about that. A lot of times you won't see any kind of on the drug lists, people either won't put anything that's a suppository because they're embarrassed, or it's just not common. We don't see that a lot. It's more for like babies that have to have suppositories and things. So you shouldn't have to worry too much about that in practice.
Okay.
I see somebody's typing. Let's see if there's a question before we keep going.
No, I was just going to say for migraines, when I was having a lot of them, they gave me an anti-nausea medicine that was unfortunately rectal. So that it was fast acting.
Yes. And, if you are nauseous from a migraine or a kidney stone, sometimes that's the only way to get the medication in.
And also, just a funny story. I was in the field, and I was in a medical unit, and I was the only dental personnel along with the dentist. But anyways, a soldier was given some type of suppository, probably for nausea, and the soldier came back the next day for rectal bleeding. Apparently, the PA forgot to have to break it down Barney style, that you have to take it out of the metal packaging.
Oh no, that's not funny.
So, it yeah. So that is why we have all those really stupid "do not do" messages and warnings on packaging. So there you go.
Thanks for sharing. Oh,
You're welcome.
that poor guy. Ugh. Okay. Ugh. All right. Let's keep going. Now we'll talk about IV. So intravascular. What does this mean? Intravascular. It's going into what?
The veins.
The veins, the vascular system. Perfect. Okay, so yes, this is the most rapid drug response and it's the best for emergency situations. So what's something we might do IV in the dental office during an emergency?
Saline.
Okay, saline. Okay. Maybe pain, yeah, if you work at an oral surgeon's office, pain or anesthesia.
Isn't there a something for heart attack we can give them IV, or is that only sublingual?
That's for angina and it's nitroglycerin.
And that's only the pill we put under their tongue.
Yes.
What if they're having? Is there something we can give them? No, that's the AviQ is a pen.
That's like an EpiPen, yeah. And that would be intramuscular. So intravascular, the only thing I can think of off the top of my head is like glucagon. If their blood sugar is low, we could give them IV glucagon. But a lot of times the things we give will be intramuscular because we're not actually going to search for a vein and inject like an IV.
Mm-hmm.
So IV is mostly reserved for anesthesia or saline during a surgery. Okay, intramuscular. So this is a sustained effect. And like you just said, the AviQ or EpiPen, that would be intramuscular for sure. Absorption, due to the high blood flow and skeletal muscle, it's absorbed very well. And massaging the muscle can increase the absorption. So usually the deltoid or the glutes. For an EpiPen, where do you see them inject that a lot? Or a AviQ?
The thigh.
Yep, stick it in their thigh. Okay, subcutaneous. This is usually for protein products. Insulin can be subcutaneous injection. Local anesthesia is subcutaneous. And sometimes we can see an abscess or a hematoma from those. Intradermal. What is something y'all had to have intradermal before you could start the program?
The TB test.
The TB test, yeah, the Mantoux test. Okay, and then inhalation is just like an asthma inhaler. Rapid delivery. Nitrous oxide is another one. And then last but not least, we have topical. So this is most effective in what kind of areas?
The mucosal areas.
Yep, non-keratinized mucosa. So these drugs have to have an increased concentration. And where would they be contraindicated?
If they're allergic to red dye. Or where or how?
Yeah, I mean that too, if they're allergic.
You don't want to get in their eyes.
Okay, eyes. And then like ulcerated or burned or abraded surfaces you'd also want to avoid. So if they have a burn from eating pizza, you wouldn't want to slather topical over that. Did y'all have a lot of downtime in clinic today?
Yeah, we had to make, I think we made like 60 or 70 burritos.
Holy Moses, okay.
There should be 8 burritos in every operatory, and then the bucket's full, and then the cabinet has some in the lab.
Nice. Okay.
We took that 2-hour CE course.
Which one?
The aerosol one.
Oh, okay. Cool. Okay, are we ready to move on to pharmacokinetics? Yes?
Yes.
Okay,
That's
so
how your body something.
it's ADME. So it's basically how the drug enters the body, circulates, and leaves. So let's do this. I'm just going to write this. Amanda, it's on page 242 of our book.
Thank you. I just found it.
Okay, so what is absorption? How is
When
something
the
absorbed?
when the drug goes into it, the bloodstream, I guess.
Yes, that's exactly right. When the blood goes into the bloodstream. I'm sorry, the drug goes into the bloodstream. Okay, what is the rate dependent upon?
How much you have, or
Okay.
how fast your body can metabolize it.
Yeah, so route of administration is really going to affect, exactly, thank you, Kathy, how it was given. Route of administration. So what's the quickest route?
Intravenously.
Yeah, IV. And what's the slowest?
Ooh, I don't know that one.
Oral.
Oral.
Yep, because remember all the steps it has to go through. Okay, so let's talk about small intestine is important for absorption of oral drugs. We have to have the small intestine for that oral drug to be absorbed. And it takes a while for the drug to get to the small intestine after you swallow it. So that's why it's the slowest. Okay, let's talk about what is D? What does that stand for?
Distribution.
Okay, so what is distribution?
Is it how long it takes for it to flow throughout your body to spread or move?
Okay, yeah, so to spread from the bloodstream to the system of the body that we want it to go to. Okay. So these are distributed to the organs with the highest blood flow. Oral goes to the liver. Sublingual goes to the heart. All right, what's next?
Metabolize.
Yep, metabolism, okay. So what happens during metabolism?
That's when the body's going to break it down.
Yes. So we're breaking it down to remove it from the body. Y'all can keep typing, even if we've already said it. Feel free to keep typing. It's good to answer it, even if it's already answered. Helps you to remember. So what else is this known as?
Oh, yes, biotransformation.
Okay, yeah, also known as biotransformation. So the important thing here with metabolism, the liver is the most important site for drug metabolism. So the small intestine is important for absorption of oral drugs, and the liver is important for metabolism. And last but not least, what is E?
Excretion.
Excretion or elimination?
And the Darby book, it breaks it down, the small intestines on each part of the intestines, what it does. Do we need to know all those parts?
I don't think so. I think that's just too much. I guess, the way I think about the board is that if you know the major concepts, the chances of you getting a question correct are higher. The strategy to try to remember every little detail just doesn't work because there's too much information. So if they're going to ask you one question about one part of the small intestine, that's one that I wouldn't worry too much about.
Okay.
Does that make sense?
Yes.
Not to make it seem like it's not important, because it is, but we can't aim to remember every little tidbit, unfortunately. I wish we could. Okay, so what happens when a drug is eliminated from the system?
Your kidneys are going to break it down and expose of it.
Okay. And when the drug is eliminated, it terminates the drug effects. So it can't work anymore if it's gone. You're right, the kidney is the most important here for this step.
Now, if you have an extended release drug, does the elimination process change at all, or is it just constantly eliminating it as it releases it?
It would be constantly eliminating it. From my understanding of time release drugs, it's all about what it's contained in, so that as it passes through the small intestine, it's constantly releasing instead of being released all at once.
Okay.
So your kidneys would just keep working to eliminate that drug.
So if somebody has kidney failure, any type of issue, extended release is probably a good medication for them because their kidneys are working overtime.
Right. And it's going to depend on what the drug is doing. If it's to help their kidneys, then it's good. But if it's if it's a high dose of ibuprofen, that's not good for the kidneys. That'll break the kidneys down faster.
Okay.
Okay. So that was ADME. That's all you need to know about pharmacokinetics. How's that feel?
A lot less than what we had to read in class.
Remember, this is just review. I'm not teaching it for the first time. All right. Do you want to keep going?
Yeah, if you don't mind.
I don't mind at all. I am available. Okay. So let's talk about adverse drug reactions. What's the first thing you think of?
Sickness, vomiting.
Yeah, so side effects, anaphylaxis, and allergy. Okay, let's break these down. Do you guys mind if I erase the screen?
No, I already took a picture of it.
Okay. All right, so let's talk about adverse reactions. So the first one we need to talk about is side effects. What are some common side effects that you need to be worried about in your practice?
Swelling.
Swelling.
Hives.
Hives. Dry mouth. There it is. Xerostomia. That's a side effect of pretty much every drug these days, right?
Mm-hmm.
So this is a dose-related reaction that is not a part of the desired therapeutic reaction. So this happens even though we don't want it to. So what is a toxic effect? When would this occur?
Is that the one where it's going to target an organ?
That's target end, I think, that you're thinking about. Target end damage.
Okay.
So toxic effects occur when the desired effect is excessive. So toxic effects occur when we take too much of something. Allergy. So this is just a hypersensitivity to a drug. What are the most common drug allergies? Penicillin.
Okay.
It's okay. You don't have to spell it on the board. I blame the keyboard. Okay. Idiosyncrasy.
What are you doing that?
So this is just an abnormal drug response that we wouldn't have expected. Can you think of any off the top of your head? The first thing I think of is like serotonin syndrome, something that we didn't expect, but because the patient has ADHD and reacts to a drug differently, like caffeine, we would see an abnormal response for that patient.
Would that be like a patient that would normally, for example, Benadryl or normal, you'd become drowsy
Yes.
and then the random person becomes overexcited?
Yes, that's
kind of
exactly
thing?
right. Yeah. Very common in patients with ADHD because the wiring in their brain is a little bit different. So then they don't react the same way to drugs. Okay. You guys want to hear a funny story about, well, it's not really funny, but my pharmacology teacher told me this story when I was in hygiene school. So there's a famous asylum in Michigan. It's not open anymore. Now it's haunted. But this asylum, they had a bunch of new people come in, and then they got a new director. And the director looked over the budget, and his job was to slice and dice, get rid of people, lower staffing, get less expensive drugs for the then they called them inmates, but they're patients, right? So this guy says, get rid of all sleeping medication. We are going to give Benadryl for sleep to all these patients. And at nighttime, we only need one guard and one nurse on staff. So what happens the first night that they dispense Benadryl to all these patients taking antipsychotic and antidepressant medications? They all, I mean, no pun intended, they all went crazy. They were all in the hallways, banging on the glass. The nurse and the guard had to lock themselves in the padded room until the morning shift came because they were so short-staffed. Needless to say, that director was immediately fired because he didn't know that he was a doctor and didn't know that there would be an interaction there. And it took months to get everything settled with the patient's family. So Benadryl, not always safe. Okay. Yeah, it is. It was nuts. And when he was telling the story, he was so animated. Dr. Middleton, he was a pharmacist that taught our class, and he was so animated. He made us our own CD with his lectures, and I mean, he was just such a cool guy. Pharmacology was a ton of fun. All right. Teratogenic effects. Teratogenic, however you say it. What does this mean?
You get these if you're pregnant. The baby can have it.
What do we see this with?
Well, drugs and alcohol.
Good. Drugs, alcohol, cigarettes. These can definitely have effects on fetus. They can have congenital abnormalities. What's another one? Do y'all remember?
Is it morphine?
Morphine, yeah. What's the song? The We Didn't Start the Fire song. Do y'all know that song?
No.
I've got no one yet.
Really? Okay, Kathy knows. Thanks, Kathy.
Kathy knows all the songs.
We didn't start the fire. You know, my husband is yelling. When I was in history class in high school, we had to memorize that song for a test. That was our whole test grade. And anyway, one of the verses, he says, "Children of thalidomide." And that was a common medication. Was it in the 60s, 70s that was given to pregnant women for nausea? And then their babies started being born without limbs. So thalidomide is definitely not a good drug for pregnant women. Another one that y'all need to be concerned with is tetracycline.
Yes.
All right. That's it. You ready to move on?
Yes.
Did you get a picture of this one?
Yes, ma'am.
Perfect. Okay. Now let's talk about the autonomic nervous system. Now this one I'm not as well versed in, but I will do my best. I have the guide right in front of me, so let's do it. So what does the autonomic nervous system do? How does it function? Okay, adrenaline. Okay. So basically it functions without us having to think about it, right? Without conscious effort. So what are some processes that keep happening even without us thinking about it? Breathing, okay. What else? Okay, heart rate. What else? Digestion, good. Laura, where are you at? Sweating, okay. The question was, what does the autonomic nervous system control for us so that we don't have to think about it? What goes along with respiration and pulse? Blood pressure, okay. Our body temperature, that kind of goes along with sweating. And then salivary gland secretion. Okay, so there are two parts. What are the two parts? ANS and the PNS. ANS is autonomic nervous system. So we have sympathetic and parasympathetic. SANS and PANS. Okay, so let's talk about sympathetic first. What do you think of when you think of sympathetic? Fight or flight. You're going to stay in fight or you're going to turn and run? And spell, I promise. Fight or flight. Okay. So this is usually during an emergency situation, like a crisis. What happens when the fight or flight system is activated? What happens to our vitals? Okay, our vitals will elevate. So why would our respirations be able to elevate for this part? What happens to our bronchioles? Okay, dilation, yeah. Good. Okay. What happens to our salivary flow? Decreased. Yeah, good. And then our neurotransmitters that we're concerned with here, do you remember what those are? Acetylcholine. That's correct. And one more. Yeah, norepinephrine. Very good. So what kind of drugs would these describe? What kind of drugs mimic the sympathetic system?
Is this where adrenergic and non-adrenergic?
Yes. Adrenergic drugs. Okay, there we go. Perfect. All right, now let's talk about the opposite. What's the opposite here of the sympathetic? Para. Good. Pans. So what does this talk about? If we had fight or flight with sympathetic, then what is parasympathetic? Rest and digest. Good. Okay. So this is our normal activity, normal or resting activity. We get increased blood flow to digestive organs. This is why they say not to eat right before bedtime, right? You want your brain to be able to shut off, not to be thinking about digesting your food. This accelerates peristalsis. It constricts, come on, Amanda. Okay, constricts bronchioles. Not you, Amanda, me, Amanda, sorry. Increases salivary flow. And now for our neurotransmitters, it's only acetylcholine. So what kind of drugs are these?
The non-adrenergic.
Yep, so these are cholinergic.
So what's the difference between adrenergic and non-adrenergic?
Let's see, like a adrenergic blocking, maybe? Is that what you're? Anticholinergic? Because there's cholinergic and anticholinergic, but there's not anti and adrenergic. Ooh, these words.
Okay.
So why don't we talk about these adrenergic drugs real quick? So we already know the effects mimic the sympathetic nervous system.
A lot of the I've taken on some board review practice tests, they talk about the constriction of pupils and which one does which one constricts the pupils and which one dilates the pupils.
Okay, so I'm gonna leave these just like, can y'all see my cursor on here?
Yes.
Okay, I'm gonna leave these just like they are. So adrenergic drugs mimic the sympathetic nervous system. So adrenergic drugs would dilate the bronchioles and the pupils.
Oh, okay.
Cholinergic drugs would constrict the bronchioles or the pupils. I guess I should have written that in there. Write that in your notes. Constricts bronchioles and pupils. It's just the opposite. So whatever the sympathetic does, the parasympathetic does the opposite. So really you only have to memorize one because you know it's opposite, okay?
Okay.
All right, so let's talk about some drugs. What are some drugs you can think of that dilate the bronchioles? Albuterol. Okay, let's start with albuterol. What does albuterol do? I just said it. Can y'all hear my husband? Sorry. Okay, so yeah, it dilates the bronchioles. So that's an adrenergic drug that dilates the bronchioles, okay? What else is another drug we use commonly in dentistry? More common than nitrous. Epinephrine. So what does epinephrine do? Well, lidocaine is the anesthetic. Epinephrine helps to do what? Good. Yeah, vasoconstriction. So we keep that lidocaine right in that area. It's also used in cardiac arrest to stimulate the heart muscle. And then dopamine. So dopamine is used to treat low blood pressure. And because it's an adrenergic drug, it's going to increase the blood pressure. So when would we want to avoid adrenergic drugs? Yeah, cardio complications. Okay, so patients with angina, hypertension, and hyperthyroidism. So let's talk about some adverse effects of these drugs. What do you think some of the adverse effects might be? Okay, good. Palpitations, cardiac palpitation, and arrhythmia. What do we see right up here? What happens during a sympathetic reaction? Okay, Kathy, we're recording, so it's okay. Yeah, more susceptible to decay, so it can cause xerostomia for sure. Okay, so basically these drugs ramp up and they would mimic your sympathetic system. Okay, let's talk about I really want to finish this part, but I don't want to erase anything. Is it okay if I erase this part right here for now? This side? Cool. Or if I can just copy that. Okay. So let's go back, and now we're going to talk about adrenergic blocking drugs. So if we want to block an adrenergic effect, what do we need? What are we aiming to do if we want to block that? Okay, yeah, we're going to calm the system instead of rev it up. So if it's adrenergic blocking, it means that we're going to calm. So Amanda, earlier when you said beta blockers, this is where beta blockers would come in to the adrenergic blocking system. So we would treat the cardiac arrhythmias. Basically, these are used to treat anything that could be caused by an adrenergic drug. Okay. So how does that work? We have to block the beta receptors. So beta 1 stimulates the heart and cardiac output. Beta 2 is going to increase blood pressure, dilate smooth muscle, and others.
Is it okay? Is beta okay? Beta 1 is only for the heart.
Yes.
And then beta 2 is just for lungs.
It can be for lungs or smooth muscle. So it depends.
So are beta blockers only for the respiratory and the cardiovascular system, or can it be used for everything?
Mostly, but they can also be used for glaucoma to smooth, the smooth muscles in the eyes.
Oh.
So let's talk about some examples of these. So, also known as Cardura. So Cardura, cardiac, just think cardiac. So these are alpha blockers for hypertension. And these are commonly listed on the board, either in the medical history part of the case study portion or within the questions for pharmacology. Inderal, also known as propranolol. This is a non-selective beta blocker. So it's going to block beta 1 and 2. But it's usually for hypertension. So the cardiologist that I talked to about propranolol, because it's a non-selective beta blocker, it's going to block everything. Oops, I spelled hypertension wrong, sorry. So a lot of times performers will use propranolol to let their respiratory system get going, or to help them calm down before a performance. If they have palpitations, sometimes this will be prescribed. So propranolol is an adrenergic blocker. Tenormin. Professor. And again, you'll see these a lot in private practice. Y'all have probably seen these a lot. Okay, so those are the most common anti-adrenergic drugs that you're going to see.
when they have us do like the OLAs or the heart or the blood pressure medications, the suffix, what do you call them? The endings, they're only on the generic drugs and not the name brand, right?
Right. Usually, if they're going to give you a drug on the board, from my understanding, it'll have the brand name and the generic name.
Okay, so that first one, the Cardura, that's not an OLAL, but it's still.
So this one is an OSIN. I'm not sure why they put an OSIN in this one. It looks to me like he flipped those two. Like doxazosin would be the generic and Cardura would be the brand name.
Okay, but it does the same. It's made for the same things like the OLALs do.
Yes.
Would they give us a question where it'll ask for one of these medications, but the only correct one is doxazosin, and we need to know the OSINs?
I doubt it, because usually if they're going to ask you something like that, it would be like, which of the following is not an adrenergic blocking drug? So you would just have to know that doxazosin in and of its own is a adrenergic blocker.
Okay. And then all these drugs that you just listed, they're going to be the adrenergic blocking to bring down or lower any type of systemic thing going on.
So it's usually hypertension, except for this one with the smooth muscle. That's going to be for glaucoma.
Okay.
Yes. Okay. Can I erase it? Okay, I'll wait a second. Do you guys mind if we take a quick break? I'm going to stop recording for a second. Okay, so we've talked about the adrenergic and anti-adrenergic. Now let's talk about the cholinergic. I'm sorry, cholinergic. So what do these mimic?
Is it cholinergic for like to increase urine production?
Yeah, so these actually mimic the parasympathetic.
Oh, for the rest and digest, the digest part?
Yeah, exactly. So let's talk about adverse effects. These are not as common, so you won't see as many of these. So the big thing for these yes, that's correct. Adrenergic is sympathetic, cholinergic is parasympathetic. Yes. So this is the easiest way to remember these. SLUD. Okay, so the S stands for salivation. So basically think of the adrenergic drugs as drying and the cholinergic drugs as moistening. L stands for lacrimation. U is for urination. D is for purification. So these are the adverse effects. This is what happens when patients take cholinergic drugs. So why wouldn't we use cholinergic drugs to treat hypertension? If inherently they would decrease the blood pressure, why wouldn't we use them?
We wouldn't use it. We wouldn't use these for a patient with high blood pressure.
But
Was
why?
that?
Yeah,
I'll go which buttons to press so I can
So basically, we wouldn't use these because of these side effects. If we gave every patient who had hypertension a cholinergic drug, they'd all be crying, urinating, and defecating way more often than they need to.
So the side effects is why we're not going to give it to them.
Exactly.
Okay.
All right, now let's talk about anticholinergic. Block parasympathetic nervous system.
So there's not going to be a whole lot of cholinergic drugs prescribed to their patients.
Probably not.
So why would it, if it causes this, would they only prescribe this if the adrenergic drugs were not working?
They would prescribe cholinergic drugs if the adrenergic blocking drugs weren't working. Yes.
Okay.
Also for patients with Sjogren's syndrome, I can't say that word, to help with the dry mouth and the dry eyes, it would help to produce saliva and lacrimation.
Okay, so they would give somebody with that disease the cholinergic drugs.
Yeah. Again, we see xerostomia because that's like on every drug.
But you wouldn't find xerostomia and cholergenic, just anti-cholergenic.
Right. So far, cholinergic is the only one that we haven't seen xerostomia because it causes salivation.
Okay. Do those cholinergic drugs end in a certain prefix or suffix?
Really, the only one they talk about is pilocarpine. And that's all you need to know.
Okay. I'm sorry.
Boy, mom. It's okay.
Yeah.
I have two brothers. Been there. Been there, done that. Okay.
Oh my gosh.
So the anticholinergic, yeah, I don't know either. Anticholinergic drugs, these block the parasympathetic nervous system. So they have some adverse reactions, but they can be used to decrease saliva flow for treatment, stop diarrhea, and stop motion sickness. So one of the questions one time asked was, when are anticholinergic drugs indicated in dentistry? So what situation would we need to reduce saliva?
Surgery.
Surgery or placing, I don't know, veneers or something, somewhere where we have to decrease the salivary flow. So that's an example of a question you might see about anticholinergic drugs. Okay, ready to move on? I would never be able to do anything if I yelled at my dogs when they walk around. They're always moving. Okay, can I erase the board?
No, hang on. Let me see.
Don't take a picture of my face though.
No, I cut you out of it.
Thanks. Okay, ready?
Is that all we need to know about anticholinergic?
That's it.
Okay.
Basically, if you know what each of those 4 types of drugs does, you should be able to answer questions from there. Like walk it back and answer those. All right, let's do it. So next we're going to talk about analgesics or pain medications. So aspirin. This is a non-opioid inhibition of prostaglandin synthesis. So do y'all remember what prostaglandin does in periodontal disease?
Doesn't it destroy bone?
That's it. It destroys bone. Good. So effects of aspirin. Do you remember? Obviously, it's an analgesic. What else?
Antipyretic.
Yep, antipyretic. So pyro, fire, makes you think of fever. Okay, antiplatelet, blood thinning. Blood thinning.
Is aspirin inflammation or is only ibuprofen inflammation?
It is an anti-inflammatory as well. So the 4 A's go with aspirin: analgesic, antipyretic, antiplatelet, anti-inflammatory.
Okay.
What are some adverse effects? Jenna said blood clotting.
You don't want to give it to children under 9 or 18.
Uh-huh.
For the
What might they get?
Ray, is it Ray? Not Raynaud's, because that's the temperature fillings. Ray's?
Ray's, yeah, Ray's syndrome. Good.
Is it children under 9 or 18 that you don't give it to?
Let's see. It just says children.
Okay.
They might go over it in the drug section later, though. I'll keep it.
I remember a question like that in Pharm.
Mm-hmm. I think it's 18, but I'm not sure. 9? Yeah, I'm not sure. Either 18 or half of it. That's 9. I can look that up in just a second. Ray's syndrome in kids and tinnitus. So it can be associated with all of these. And a lot of times on the board, they'll ask you to select an appropriate over-the-counter analgesic medication for your patient. And you have to keep in mind for their medical history. If they have ulcers, they can't have aspirin. If they have asthma, they can't have aspirin. If they have tinnitus, they can't have aspirin. So just keep an eye on those medical histories. All right, next. Ibuprofen. Usually ibuprofen is, yeah. So this is an NSAID, commonly known as Motrin, Advil. The effects here, it is an analgesic, antipyretic, anti-inflammatory, and it also has an antiplatelet effect. It's just not as pronounced as aspirin, so it's not recognized for that most of the time. Okay, so what are some adverse effects of ibuprofen? Yep, GI. The other big one is that it can interfere with clotting. So this would be contraindicated for patients with gastric ulcers. And it also can decrease the effects of other drugs. Do you remember some of the drugs that can decrease the effects of? No? That's okay. Okay, so that would be ACE inhibitors, aspirin, beta blockers, steroids, diuretics, and lithium. So patients who are bipolar, you could not prescribe this for. Patients who are taking aspirin as a blood thinner, patients taking beta blockers, steroids, and diuretics. Okay. And then we have narcotics and opioids. This is a hot topic right now, so I have a feeling you might see these. So the big thing here is that these don't actually help with inflammation and therefore reduce pain. They just block the receptors in the brain for the pain response. So very different mechanism than an NSAID or other analgesics. All right. So what are the effects of narcotics?
Don't these block the receptors so they can't feel anything?
Exactly. So the pain is still there, they just don't feel it. Drowsiness, slows down, constipation. Okay. Yeah, so they are definitely pain reducers. They're also cough reducers, antitussives. They cause sedation and euphoria. And the last two there are the ones that make these it puts them on the schedule for drugs because there's an abuse potential for those two. So for the sedation and the euphoria. And the adverse effects, like you said, constipation, respiratory depression, nausea and vomiting, and addiction. So they may ask you, due to the adverse effects of this narcotic drug, what sort of patient could not take Vicodin or something like that. So we've got morphine, Tylenol 3, codeine, Demerol, Dilaudid, and Vicodin. If y'all, as a note on practicing, if your patient comes in and asks you specifically for Demerol or Dilaudid, chances are that they are a drug seeker. I hate saying that, but that's just how it is.
We had a patient come in, and there's a website you can look them up at.
Mm-hmm.
It's really cool.
Yeah, and it's a statewide registry that the pharmacies use. So regardless of what provider they go to, the pharmacy has to report to that website. So they can refuse to fill a prescription if they've already had too many.
We had a patient come in, and the doctor asked me to look it up because I was the one that did it. He gave me his information, and I had to go sit down and tell the patient. I was just flat out blunt with them. I said, well, you've already been to 9 different pharmacies this week and got prescriptions. We're not going to give you anything. So do you have a toothache, or is there something else we can take care of? And they just walked out.
Yep, that'll happen. So sad. Okay, another thing they're asking a lot about now is Narcan or naloxone. That's the spray, and most EMTs carry this. I mean, all EMTs should carry it by now to treat opioid overdose, like for heroin. Mm-hmm. And then in this little square over here, I know I'm running out of room, but I'm going to do a little bit about methadone. This is usually used in the treatment of patients with narcotic dependence. And it suppresses the need for narcotics. So what you need to know about methadone, if a patient is already taking methadone, we can't use nitrous and we cannot give them a prescription for opioid or narcotic. It's usually for recovering addicts. So if we give them a prescription for what they're addicted to, clearly we're not doing what's in their best interest. Y'all just let me know when you're ready to move on and we'll go to antibiotics. Ready? Okay, let's do it. I'm going to erase the board. All right, so now we're going to start talking about antibiotics. Did y'all cover this pretty extensively?
No, one class he just listed all of them and certain things, and that's all we did.
Okay. All right, so let's talk about what antibiotics are for. What do we use antibiotics for?
To kill bacteria.
Yep, exactly. Fight infections, but only bacterial infections. This is why a lot of patients come in with a cold or the flu demanding an antibiotic, and it's actually not going to help them because antibiotics only kill bacteria, not viruses. So one big problem with dentistry right now is that we have overprescribed antibiotics in the United States. And now we're seeing that a lot of bacteria is resistant to antibiotics. And then spectrum. The range of activity of a drug. So what, y'all, can you tell me an example of a broad spectrum antibiotic?
Or would penicillin be one?
Absolutely. Penicillin, a Z-Pak, those are both really common. Now, what about something that is more focused? Like for perio, what would we use for perio because it concentrates in the GCF? Tetracycline. Yeah, good. Okay. So tetracycline is considered to be a broad spectrum antibiotic. However, if we use it for a specific purpose like that, it makes it a little different than penicillin. All right, so let's talk about penicillin. What are some common names for penicillin?
Amoxicillin.
Menton. Okay.
Augmentins and penicillin?
Mhm.
Okay.
It's an amoxicillin with an acid added to it. So the things to know, this is the most commonly prescribed in dentistry. It's bactericidal. It's the most likely to produce anaphylaxis. The most common side effect is a rash. And it is safe for pregnant patients, unlike tetracycline. Now let's talk about some macrolide antibiotics. These are also bacteriostatic, and they're often used for pre-med in dentistry. So when would we use these drugs? The macrolides instead of a penicillin.
What's a macrolide?
Like clarithromycin or erythromycin or azithromycin.
Do those do something different than the I don't know, I'm confused now.
So the mycins are different than penicillins. You've got
Okay.
psyllin and mycin, psyllin or mycin. So they are a little bit different, and sometimes we can give these to patients who are allergic to penicillin and to the what's the other one I want? Cyclines, no. Cephalexin. So if they're allergic to both, sometimes we go to erythromycin.
Okay, so penicillin is different from the mycin.
Mm-hmm.
Okay, but they do the same thing. They're just different.
They're antibiotics. So this one is bactericidal. This one is bacteriostatic. So it's a little bit different. This one kills bacteria and this one inhibits the growth. Oh, I spelled inhibits wrong. Sorry. Inhibits. That's fine. Okay. Tetracycline, you ready?
Is that all we need to know about the mycins?
That's it for now. We'll also go over some other antibiotics on the other side. And we'll talk about pre-meds and what to use specifically for pre-med.
Okay.
Okay, tetracyclines. These are very broad spectrum. And they're bacteriostatic. They're usually used for treatment of acne and penicillin, bacterio infection, nub, and nup. Contraindicated for pregnancy. Y'all know that. No dairy, iron, antacids, because dairy, iron, and antacids will all bind with tetracycline and then it won't be able to be absorbed. Have y'all ever taken a tetracycline drug?
I am right now for acne.
I took one for an upper respiratory infection and it made me so sick. It was my brother's wedding weekend and it made me so sick. I had to get Zofran and it was just terrible.
Really?
I could not believe it. Yeah.
Wow.
I know. She was like, "You'll be fine." I was like, "I'm not fine and I am not in the state. I need you to fix this for me." Okay. So the examples are minocycline and doxycycline. That's what I was taking, doxycycline, and it made me more sick than I've been from any other medication. All right. So let me know when I can erase the board and I'll continue with the other antibiotics that are common.
Okay.
Okay. Now let's talk about cephalosporins. These are similar to penicillin, but 10% of patients who are allergic to penicillin are also allergic to Keflex. So that's where we have to be careful about what we prescribe for a pre-med. And I wrote myself a little note here. Usually the board will use the generic and the brand name, so you don't have to remember which is which. Mr. Garcia is calling me. Can y'all hold on a second? Okay, so Keflex is a really strong antibiotic. Sometimes when you see patients on that, they will end up having thrush because all of the good bacteria is gone from their mouth. And Ceclor and Ceftin, not as often as Keflex. You'll see that one quite a bit. Antibiotics used to treat tuberculosis. We've got rifampin, isoniazid, pyrazinamide, and ethambutol. So all four are used at the same time to treat. Most of the time, patients will stay on rifampin. Sorry, not fifampin. Absolutely. We are going to keep recording, so if you have to go, that's okay. I'm just probably going to finish antibiotics and then probably pick it up again tomorrow, if that's okay with you guys, and keep recording. It's dinner time. Whoop, whoop. You're welcome. Okay. Clindamycin, this is usually a good alternative for penicillin, and then Flagyl, that's usually for NUG. Okay, perfect. So you'll only see that used for NUG usually. This is one they give in the hospital settings, so you probably won't see a whole lot of patients on that. Okay. Can I keep going? Can I erase this one?
The tuberculosis drugs, are they considered cephalosporins?
I'm not sure about that. They're
Okay,
just kind of, yeah, they're just in their own. And it depends. Like some of them are IDs, IDs, PINs, you know, so they're probably different. I'm assuming since they have to have four that they all do something different. Like one is bacteriostatic, one is bactericidal kind of thing.
Okay, I didn't know because you had cephalosporins at the top. I didn't know if it was a continuation of it.
No, I'm sorry, that's a separate one. So cephalosporins ends right here with the examples. And then antibiotics, this is supposed to be rifampin, not fifampin, sorry. But those are just the antibiotics for TB.
Okay.
Okay. So I'm gonna erase this. Now we're gonna talk about pre-meds. So any medications for pre-meds. Antibiotic pre-medications. This is specifically for dental procedures. So conditions that require pre-med. Do you remember any of those?
It was infective endocarditis. Was artificial joint still in there?
No,
Um,
but artificial heart valves are.
artificial heart valves. So they don't need it if they have mitral valve prolapse, but if they have that valve replaced.
Exactly, if it's an artificial valve replacement. But if it's like bovine, it's fine. Or cadaver, that's fine.
Is bovine an osteoporosis medication?
Bovine implant is like it's from a cow.
Oh, yes. Okay. It was the type of.
Repaired with patch.
32 headshot versus. You see somebody? Yeah, I killed someone. Thanks for your help. This is me.
Okay, so that's all of the things that pre-medication is absolutely required for. And then may require, but not necessarily.
Oh, no, don't kill him, don't kill him. Is he going to be our friend? No, I want to lose. Come on, see. Come on, safety, okay? Wait, I'm going to pick up this gun.
So for this, the may require section, basically what you're going to be asked, if in doubt, refer to the primary care physician. These aren't usually asked on the board because there's no definitive answer. These have a definitive answer and they will probably be on the board, but these not so much because we can't say yes or no absolutely.
Okay. Here, can you res me, please? Just res me.
And then last but not least, recommended drug regimens. So amoxicillin, 1,000 milligrams, 1 hour prior. Allergy to amoxicillin, cephalexin.
What's the difference between a shunt and a stent?
A shunt is where it's actually draining from the head. So they would have a little tube that drains. A stent is inside, basically. So a shunt drains and a stent stays inside. Let me double check that because I say it and then I'm like, oh, is that right?
I have. You just can't. We're playing creative in a couple of rounds, okay? Huh? I'm gonna play creative with you in a couple of rounds.
Okay, so a shunt is a tube that connects two previously unconnected parts of the body to allow fluid flow. And a stent, come on. A stent is to like keep something open. So in the heart, they would put a stent in to open those arteries when they're blocked.
Okay.
So a shunt is to drain, a stent is to maintain. Does that make sense?
Yeah, it does, and it kind of rhymes.
Yeah, I like the rhymes. That helps. Okay, so those are the most common drug regimens for pre-med.
Okay.
And those I don't really have a trick, like you just kind of have to memorize them, unfortunately.
I know the amoxicillin 2,000 milligrams, and the clindamycin.
Yeah, those are pretty common. You've probably seen those out in practice quite a bit. So I'm gonna give myself a little sticky note where we stopped. Yeah, Keflex. You'll see a lot of people on Keflex that can't take amoxicillin because of other medications.
Right. Okay.
So any questions on the antibiotics or anything that we covered up until now? So we got through about 8 pages. And we have about 10 left.
Okay.
So it's not too bad. Yeah, absolutely. I'm gonna stop recording.